Good afternoon, everyone. Today's lecture is by Dr. Josiane Pinto, who will be presenting a paper presentation on PIVD. Dr. Josiane has completed her master's in orthopedic manual therapy from KLE Institute of Physiotherapy. Before we begin, I request everyone to mute their mics to avoid any disturbance and save your questions till the end. Over to you, Dr. Josiane.
Disclaimer, this talk is intended for educational purposes only. It reflects our opinions and are based on our best judgment, but no warranty is given or implied as to their accuracy. So today's paper presentation, its title is A Nerve Root Decompression Position Identified by 3D CT Scan, the Modified Reversed Contralateral Axial Rotation Position for Patients with Lumbar Disc Prolapse. The authors are MRCAR et al. So introduction. Lumbar intervertebral foramen (LIDF). It acts as a critical exit route where lumbar nerve roots and mixed spinal nerves are highly susceptible to pinching or compression from various spinal disorders. So think of it as a door hinge and think of it as something going through a door hinge. Here we can see the anatomy. Here we have this exactly is the intervertebral foramen. And the two articular processes of the superior and inferior vertebral segments, they form a zygapophyseal joint. So that is here. This is the intervertebral foramen and this is the intervertebral disc. Here again we see the anatomy from a side POV. There is a superior vertebral notch. The intervertebral foramen, here you can see the spinal nerves exiting, the superior articular process and the inferior articular process, which then form the zygapophyseal joint. Now the size of the lumbar intervertebral foramen, it shifts constantly during daily movements. So consequently your posture decides whether the symptoms are worse or whether the symptoms are better. Positional decompression is a technique that is used to relieve this pressure without surgery, and it is a manual therapy technique which is designed to open up the spinal doorway and alleviate nerve irritation. So because we've decided that, and we've come to the conclusion through various studies that different postures can affect the level of symptoms, the level of pain that you experience. Hence, there is a positional decompression and there are various techniques that have evolved throughout time that help with relieving this posture, relieving this pain just through appropriate correct posture and without surgery. Let's look at the evolution of this technique. So in 1993, CDAX first introduced the reverse rotation strain, which was just lumbar twisting, that is axial rotation, as a manipulation method. And then we went on 3 years later, 1996, Winkle et al. He adapted this into an axial separation in flexion. So mobilization technique, which was focusing on stretching the spine, rotating it, or combining both movements. So we started with reverse rotation strain, which is you turn in the opposite direction and as the symptomatic side. And then we added traction, basically separation to it, axial separation. Few years more down the line, 2003, Ombrecht et al., they reutilized this specific therapeutic posture as manipulation technique known as the reverse stretch. So, evolution of spinal modeling and imaging. Now, the beauty of this study is it combines this intervention along with, it gives you like an in vivo look of what is happening within the articulating structures. So, past research into the physical structure of LIDF relied on fresh cadavers in laboratory settings. However, these studies were limited because they could not replicate the natural muscle tone of a living body. So, naturally, there are muscles and tendons and all these primary structures that are there which stabilize and help with the movement. But in a cadaver, you will not see these things in action. So, early simulations, computer simulations and biomechanical studies, they fail to account for all these little factors. And with cadavers, of course, you are not able to see these things. But now we have come to a point where there is MRI and CT, and while traditional MRI is performed on living patients, it does not always provide complete details and can occasionally lead to imprecise conclusions. So recent breakthroughs in computer technology and digital modeling now have enabled researchers to analyze complex 3D shape of spinal structures, such as this study works with computerized tomography, which is 3D. So this study introduces a modified version of traditional reverse rotation strain position called the modified reverse contralateral axial rotation, MRCAR for short, which will be looking into how it is done. And a multiplanar approach. Unlike basic movements, the MRCAR is a highly specific three-dimensional posture. It simultaneously combines three movements. So there is movement in the transverse plane with the lumbar axial rotation. There is side bending, so that is in your frontal plane. And there is flexion, so that's in your sagittal plane. Now, the aim of this study was to explore real-time and short-term influence of the MRCAR trunk posture on the cross-sectional area of the lumbar intervertebral foramen and straight leg range in patients with unilateral lumbar disc prolapse and radiculopathy using 3D CT scan imaging. So all the components in this aim, first of all, the individuals chosen, the inclusion criteria was to have obviously unilateral lumbar disc prolapse, and it was only a short-term influence of MRCAR on the trunk posture, and they've also checked the cross-sectional area, as well as the other outcome measure is straight leg raise. So before the study, right after it, and a little while after it again, at different time frames, the SLR was performed. Now the instrumentation. Lumbar 3D CT scan was performed using Philips Brilliant 64 multi-slice CT scanner. All the data was obtained using an integrated positron emission tomography and computed tomography, that is PET CT system. This system combines PET scanner and multi-section helical CT scanner, allowing for the capture of CT and PET images simultaneously, hence the 3D effect. The CT technologist was well trained and qualified to ensure that radiation doses are kept as low as reasonably achievable in every scan in order to obtain high quality images with minimized radiation exposure. Now the materials and methodology. The sample size and allocation. So there were three groups, A, B and C, and 90 male patients were taken with one-sided, that is unilateral lumbar disc prolapse and nerve root pain. Now for women, the reasoning that was given why women are not included in the study is because of the hormonal changes and the cycle of changes, the menstrual cycle of changes that we go through. Because relaxin is also at some point in our cycle in higher levels, it would have an effect on the pain, and hence it would cause like an internal bias, and that is why only male patients were included in the study. Now, these 90 male patients were divided in three groups based on the affected spinal level. So, L3, L4 level was group A, L4, L5 level was group B, and L5, S1 level was group C. Patient underwent 3D CT scan imaging at a radiology center specializing in the spine. Those meeting the inclusion criteria agreed to sign an informed consent form, and this research was authorized by Research Ethical Committee of the Faculty of Physical Therapy, Cairo University. Now, the inclusion criteria. Participants were aged 20 to 40. Again, why were individuals above 40 not included? It was because they wanted to exclude individuals who are undergoing the natural degenerative processes due to age. and they wanted it to be purely in this age range because above the age of 40 you start to see degenerative changes. Grade 2 paracentral or foraminal disc bulge measuring between 2 to 3 mm, which was confirmed via MRI scans. The ratio of pedicle height to vertebral body height was restricted to 0.5 mm. Low back pain and one-sided radiculopathy for a minimum of 3 months were the symptoms that had to be there in the history, alongside a positive SLR test. So the condition status was confirmed through a comprehensive physical and neurological testing, including reflex, sensory, and motor function evaluation. The exclusion criteria. So bilateral or multi-level disc prolapses were excluded. Sequestrated, migrated, calcified or herniated discs were excluded. Posterior apophyseal ring separation or modic changes were excluded. Piriformis syndrome, SI joint dysfunction, or sudden acute onset of pain were also excluded. Now the imaging itself. The 3D CT scan images were acquired on 3 occasions. So baseline was image 1, image 2, and then immediately after was image 3 after 48 hours. So baseline image 1, the first image was captured in the conventional neutral supine position, providing baseline data. So let's look at the image. This is the baseline in a neutral supine position. Now, image 2, the patient assumed a sideline position on the pain-free side. This position was standardized by placing a hard wedge pillow measuring 30 centimeters in height and 75 centimeters in length beneath the pelvic region, keeping the upper edge of the wedge pillow base just above the level of the iliac crest for all patients. So the patient was in sideline position on the pain-free side. There was a hard wedge pillow that was 30 by 75 centimeters that was kept beneath the pelvic region, just near the, just above the level of the iliac crest, and this was maintained the same for all the patients. The patient was then positioned in the modified reversed position posture by rotating the trunk away from the painful side opposite to pelvis rotation. We'll look at a few more pictures after the description. While ensuring the lower shoulder and upper pelvis remained aligned. Both arms were resting on the bed with shoulders abducted at 90 degrees. So let's have a look. Here we go. So rotated in the opposite direction, both arms were held down. Forearms were hanging off the bed with elbows flexed at 90 degrees. The hip and knee of the uppermost limb were fully extended while the lowermost were flexed to approximately 90 degrees. So the hip and knee of the limb that was on top were fully extended, and the one that was lower was flexed to 90 degrees. And the third image was the same posture, but it was only acquired 48 hours later. This is when he was trying to assume the position with the wedge, and this is the final position. So we see the uppermost, that they said upper limb, lower limb is extended completely, whereas the lower limb, the lower limb is flexed at the knee approximately 90 degrees. Both the forearms are supported on the bed and hanging, and the axial rotation is in the opposite side of the plane. So the lowermost hip and knee bend to 90 degrees, uppermost hip is hyperextended with extended knee, trunk is rotated into semi-prone position in a direction opposite to pelvis rotation. The trunk is laterally bent, and to induce a level of flexion, they've kept a wedge underneath, just near the iliac crest. We have a video that will quickly explain the position, so we are a little more clear with it.
Welcome back to Therapy Thursday. You've thrown your back out. It can be super frustrating both for you because oftentimes it's so difficult to give huge care management advice. If you just want the pain to decrease, you can actually start to work with the individual. There's a number of gold standard positions. I'm an advocate of the McKenzie method, where it's a lot of extension-based care for the majority of acute low back pain patients that are likely or suspicious they may be experiencing pain from a lumbar disc. So what is a lumbar disc? Each one of these guys are vertebral bodies in between you've got a disc. You can see when it bulges out to the side, it can make contact with the nerve root, and that's often what causes sciatica or pain down in an individual's leg. A new paper came out this spring, so the spring of 2025 for those watching in the future, that commented on a new position they tried. So this paper was interesting because it's the first one that looked at CT images of these individuals that showed an enclosure because of the disc bulge around the space for the nerve, and they had this position and they came back and did it again, and then again 48 hours. It also decreased their objective findings, and it most significantly substantially decreased individual pain. So what is this position? It's called the modified reverse contralateral axial rotation position. It's a mouthful, I get it. So I'm going to show you what that position looks like. But the essence of it is that you're trying to put the body in a position, let's say this is where a disc bulge is, that you are opening the space as seen there for the nerve root itself. So the way that they chose to do that was they had the person side lie, like so. Their top leg would go into extension and their bottom leg up to 90 degree angle, and then they would rotate down and hug the table like so. Now, to even accentuate that position a little bit, they would have an individual lay on something like a 15 to 30 centimeter block just above their iliac crest, so just above the side of your head. The symptomatic side is this top side because that's the one that you're trying to parse to open up a little bit. Now, again, this study had excellent findings, but there's a few caveats. First and foremost, it was on younger, healthy people. So these people had a history of at least 3 months of severe leg pain going down their leg.
So we've seen the positioning. He lies down on the pain-free side. The painful side is on top. He turns in the opposite direction. The leg that is on top goes into full extension of the hip and hyperextension of the hip, in fact, and extension of the knee. And the lower limb, which is the non-affected side, it goes into 90 degrees of hip flexion, and he described it as hugging the table, which is your forearms are hanging off the sides. Now let's look at lumbar 3D CT scans. So here you can see the left images are from the supine position where they are just lying straight, the image 1. And this is the right image is from the modified reversed contralateral axial rotation position. You can see a difference in the disc bulge slightly. You can see reduced space here, and here a little bit. And here you can see where it is a little more neutralized slightly. The same with this image. These are the baseline images. Again, this is showing you the intervertebral foramen that we had seen in the first picture of anatomy. So here you can see the disc bulge. Here you can see a sharp outline, and here you can see it slightly more rounded and the space a little more increased, and the same here. This shows the cross-section areas difference, pre and post. Baseline, immediately when the position was done, and 48 hours afterwards. That is the image 3. And you can see a distinct difference in the cross-section area. Now the images interpretation. The cross-section area of the LIVF was measured from the true sagittal plane at the L3, L4, L4, L5 and L5, S1 levels using boundaries of the neighboring superior and inferior pedicles, the posterior superior part of the lower vertebral body, the back part of the intervertebral disc, which we saw in the first image was like a sharp outline, whereas in the image 2 and the image 3 was a little more subtle, rounded, and increased cross-section area. Now, the therapeutic intervention that was given. All patients were educated and instructed to adopt this position 4 times daily, each lasting 20 minutes for a period of 48 hours between image 2 and image 3 acquisitions. Now, image 2 was immediately after the supine image. They asked them to perform the intervention technique. They put them in that technique, and then 48 hours later, they went for the image 3. As the hip and knee of the uppermost limb were fully extended, the patients were educated to exert a gentle post-end range push in backward and downward direction as much as possible to ensure the optimal and maximal positioning, that is self-augmented maneuver. That is, self-augmented is when they were doing it at home. So they had to adopt it 4 times daily, which each lasted for 20 minutes. Now, the outcome measures, the angle of the SLR test was assessed to detect nerve root irritation and potential entrapment, causing reduced nerve excursion. It was assessed as an initial baseline response following image 1, and then it was measured after image 2, and finally after 48 hours after image 3. The SLR test of the affected lower limb was performed in the supine position. The examiner placed one hand on the patient's knee, keeping it extended, and the other hand holding the heel. The patient's leg was then slowly lifted until the pain was felt anywhere in the affected limb. Once the patient was reported feeling pain, another examiner measured the angle between the bed and the affected limb using a universal volumeter. Now, coming to the results, the table 1 shows you the descriptive statistics, and this table usually gets evaluated to check homogeneity in all the values. So, age, body mass in kgs, height in centimeters, and the BMI, and it was found to be homogeneous and hence applicable for to analyze and to evaluate. Table 2 shows you the descriptive statistics of the cross-section area of the lumbar intervertebral foramen, and table 3 shows you of the angle of SLR test. So the plus and minus that we see is the this standard deviation, and 0.255 in group A was baseline image for our cross-section area, and in image 2 we see it has gone up to 0.369, that is centimeter square, and then finally after 48 hours it's gone to 0.691, which is a significant difference if considered in centimeter square. Group B is 0.171, 0.269 is the increase, and finally 0.566. And in group C, it started with 0.134. After the initial positioning, it was 0.202, and finally it was 0.441, which is also significant. Now, table 3 shows you the SLR test. Again, it started with 41 in group A, 35 in group B, and 29.26 in group C. And in image 2 and image 3, you can see there's a significant difference between the two. It started with image 2 was 44.80 group A, 41.53 group B, and 35.93 in group C. And then it all went into the 60s in the image 3, that is after 48 hours for the SLR test. So it went to 65.83 degrees for group A from 41 initially, and 69.63 in group 3 from 35 originally, and group C was of course 65.23. So here again we see significant changes from the baseline. So the participant demographics and baseline data, the first table that we saw, they were well matched at baseline, which is they were all at a reasonable level of similarity, because if there was too much of a difference and they were not homogeneous, the results would be considered slightly biased. Now, the main intervention effects, the 3D CT scan, the impact of the interventions was evaluated. This analysis revealed a highly significant main effect of the three 3D CT scan images on the primary variables of interest. A statistical significance indicated that the physical changes captured across the different scan intervals were substantial. As we saw in the previous tables, there was a big margin of difference, especially in the SLR, and also there was a significant difference in the cross-section area in centimeters square. When comparing the image 2 back to the baseline, a statistical significant increase was observed in both the cross-sectional area of the LIDF and angle of SLR. The third scan showed that the upward trend continued, as in it increased with the immediate positioning, but after 48 hours it only increased even more. The final phase maintained a consistently large effect size across all tested groups, indicating robust and sustained improvements over the course of the study. Now this shows you a graph, puts it in a more visual perspective, the cross-section area of the lumbar intervertebral foramen. So you can see how high it scrapes, the red cylinder, which shows you post 48 hours, the image 3, the same here and the same here as well. And the green ones would be when the image 1 were taken, that is in supine. Blue would be the initial positioning for the first time, and then group this red one would be after 48 hours, and practicing it 4 times for 20 minutes each time. Now, angle of SLR as well, we can see how significant the difference is with the red cylinders. So, as we saw initially in the evolution, it came down from first axial rotation, then they've added components. So first there was axial rotation, and then they added a degree of separation like a distraction, and then we had uniplanar and we have multiplanar. So what is the difference between your classic reverse rotation position and your MRCAR? So it is multiplanar. They add this wedge in between, which gives you flexion, basically involving the sagittal plane, whereas here you only had like the transverse plane, and here you have the all of the planes are involved. So looking at the anatomy during MRCAR, this is in supine position. There's no rotation, there's no side bending, no flexion, no extension. In MRCAR, there is ipsilateral lumbar rotation, ipsilateral lumbar side bending, and lumbar flexion. So this is the transverse view. There is elongation here. So if I'm turning towards this side, there is elongation on this side where there is pain. Say I have pain on my right side. So me turning this side will cause like a distraction here. Then again me bending towards this side will cause a distraction on this side. And then the same thing with lumbar flexion. Now this is a schematic model of the LIDF dimensional changes during the modified reverse contralateral axial rotation and supine positions. So the different colors represent the different structures. Yellow is for nerve, artery is red, and blue of course is vein. So you can see them here, and you can see how congested this picture looks. It looks compressed, whereas you can see here not as compressed. And now the transverse view, this is in supine position. Again we see that it's nearly compressed here on this side, and here it's a little more free compared to that. But then again on the MRCAR positioning image, you can see that it is no longer as compressed. Again, this shows the same thing. These are the lumbar MRI images. They show, this one is at the L5S1, and this image, it depicts the MRCAR position. So you can see there's not as much compression here as there is here. So it is reduced. Now the SLR testing angle after and before. So before the positioning, when they had done the test, this is the same image as before. Here, there is a compression, but once that compression is reduced and there is more space here, there is a negative SLR test. So there was no recreation of symptoms. And we can see at a lower angle. Now the discussion. The MRCAR position significantly increases the cross-section area of the lumbar intervertebral foramen immediately when used as a therapeutic intervention for 48 hours. The MRCAR position resulted in further improvements in the cross-section area of the LIVF and the nerve root mobility as measured by the SLR test. Lumbar radiculopathy is predominantly a consequence of disc-induced nerve root impairment. So compression and impediment to normal movement of the nerve root occurs when the lumbar intervertebral foramen space is crowded by the displaced disc. Although LIVF stenosis is clinically important, there was limited data, in vivo data available on how this geometry changes in specific trunk positions. So we knew that from early on, we saw the evolution of it. We knew that different positioning, different postures can relieve the pain, but there was never a study that showed you in vivo exactly what happens to the structures, and this study did exactly that. Studying the investigating effects of MRCAR position of the trunks on the cross-section area and of the LIVF in patients with unilateral lumbar disc prolapse and radiculopathy using 3D CT scan technology. So the findings of the current study, they reveal a statistically significant immediate and sustained increase in the LIVF CSA in the MRCAR position when compared with the supine position across all tested groups. So we saw there was a group A, B and C, and all three concluded with the same thing, that there was a significant difference in between the results of image 1 versus 2 or 3. Previous research has examined the morphological alterations in the LIVF during lumbar flexion, side bending and axial rotation. It has been established that flexion led to a significant increase in width, height and area of the LIVF, while side bending resulted in a significant increase in the width, height and area of the LIVF on the opposite side of bending, and axial rotation led to a significant increase in the height and area of the LIVF on the opposite side of rotation. The findings of the present study are also consistent with this earlier researches. So a study by Creighton stated that lying on one side over a 6-inch diameter tower roll improved the AP and vertical opening of the LIVF at the opposite side of lumbar bending. And another study by Singh et al. Reported that some positions such as lumbar extension may reduce the LIVF dimensions and cause potential spinal nerve root injury. So basically two studies. One study is saying that lying on one side causes a vertical opening of the LIVF on the opposite side, and the same thing the other study is saying, that if you lie on the same side and then you perform extension, it will reduce the space and hence cause compression, obviously. And other positions such as flexion or side bending, they increase LIVF dimensions and reduce the nerve root compression. Unilateral lumbar disc prolapse causes radiculopathy through mechanical compression, vascular disruption, and inflammatory mediators from the herniated disc. So this is speaking more about the pathophysiology of this disc bulge. This compression compromises the nerve root and spinal nerve complex via ischemia, obstructed blood flow and localized inflammation. Additionally, mechanical stress induces nerve root degeneration triggering a macrophage-mediated chemical release that worsens this radicular pain within areas of Wallerian degeneration. Expanding the LIVF can reverse this process, easing symptoms and restoring neurological function by relieving pressure on sensitized nerves. So in this study, the MRCAR position significantly increased SLR test ranges compared to the supine position across all groups. This indicates that the MRCAR posture relieves nerve root compression and circulatory impairment. An increased SLR angle generally correlates with reduced neural tension and improved nerve mobility, which can lead to symptom relief. Specifically, an improvement of 10 to 15 degrees in SLR is associated with functional recovery and reduced pain in patients diagnosed with lumbar disc herniation. So in this current study, the observed increases in the lumbar intervertebral foramen cross-sectional area and SLR angle exceeded previously reported ranges. This reinforces the hypothesis that the MRCAR position could serve as a valuable clinical tool for enhancing functional capacity and pain management. So this position utilizes movements opposite to the standard postures typically employed to induce the centralization phenomenon in patients with lower extremity referred to. So about centralization, it is most frequently achieved through lumbar extension, but as we saw, there was a study before in the discussion itself that told us that lumbar extension may cause decreased LIVF space and increased pressure on the nerves, more compression. So either alone or combined with ipsilateral side bending. Because centralization is closely linked to discogenic pain management, it serves as a reliable guide for determining the mechanical loading direction required to achieve lasting relief from referred pain. Anyway, furthermore, this MRCAR position, it offers a viable alternative to traditional prone or sideline positions during physiotherapy modalities. Hence, it is also advised that physiotherapeutical electrical modalities can be given to these individuals with the same symptoms in these positions, because as given in the intervention of the study, they were asked to practice it 4 times for 20 minutes each, and a session of TENS or IFT would typically last 15 to 20 minutes, so it would fit in. And this can be readily integrated into a patient's home exercise program as well. Now, the limitations of this study. The study was restricted to young male volunteers with unilateral L3, L4, L5S1 disc prolapse and L4, L5 also, meaning outcomes could differ across genders, age groups and distinct spinal conditions. Also, as we spoken about it earlier, it was not inclusive of women due to hormonal fluctuations, and so a wider study needs to be conducted, also including women, working around the whole hormonal cycle conundrum. Now, the ethical risk constraints. Establishing a symptomatic control group was unfeasible due to the ethical concerns of performing multiple CT scans within a brief time frame. So that kind of exposure to radiation within a span of 2-3 days would not be ethical, and hence there was no asymptomatic control group. Follow-up duration. The evaluation of the MRCAR position as a conservative treatment pathway was limited to radiological monitoring within 48 hours, necessitating future longitudinal clinical studies, because this was only done within the span of 48 hours. A longer study would have even more significant results. Procedural variability. Although the MRCAR position was strictly standardized, minor inter-operator variability during patient positioning cannot be entirely ruled out. Conclusion. The modified reversed contralateral axial rotation position of the trunk opens up the LIVF, lumbar intervertebral foramen, at L3, L4, L4, L5 and L5S1 levels. It improves SLR range of motion in the short term, that is 48 hours, and it has a real-time decompression effect on the impinged nerve roots. As a novel finding, it has potential clinical value as a manual positional nerve root decompression treatment technique for patients with unilateral lumbar disc prolapse and radiculopathy who do not respond to other conservative measures. So as far as conservative measures go, it has been considered it has like great clinical value to resolve symptoms conservatively at least. And that's it. Thank you for your attention.
Thank you, Dr. Josian, for the informative lecture. Does anyone have any questions?
Hello. Hi, can you hear me?
Yes, ma'am.
Yeah, so Josian, Dr. Josian, lovely presentation. You did a great job. So this article is very good in the sense it talks about the positioning. Now the important thing is how can we use this position clinically to relieve pain. So we can use this positioning, ask the patient to adopt this position, and we can apply tests to it. We can do neural mobilization in this, as a physician can do neural mobilization in this position, at least in the parts that we can do, like moving the ankle, moving the knee, certain situations. So this is very usable. This is a lovely presentation, and what is the best part about it is the discussion. So they've explained every component well, and as you said, they have done an MRI also. So it's a treatment technique with an MRI. So that has given it more credibility. So overall, a great presentation.
With this, we conclude with the session. Thank you, Dr. Josian.